morning, sir. On behalf of the Panacea Biotec Limited, I welcome Dr. B Agarwal, President Mumbai Hematology Group, and a very warm welcome to Dr. Soniya Nityanand. Ma'am, on behalf of the entire Panacea Biotech team, I congratulate you for being elected as a director for RML Hospital, Lucknow.
Thank you.
Thank you, ma'am. And a very warm welcome to Dr. Professor Prakash Chitalkar, one of the very old supporter of Panacea Biotech, who's a professor and head of pediatric hematology in Sri Aurobindo Medical College, Indore. Sir, I have a small presentation what Panacea is today. Would like to present it to you all. Just wanted to share with that what Panacea today is. We are the number 6 in vaccine business, and we are the 10th pharma company in represented market, and we are the 15th biotechnology company in India. We are among top 50 companies who are the innovators in India, and we are the 6th among WHO pre-qualified suppliers of the pentavalent vaccine around the world. We are proud to have EZ6, the first fully liquid-based hexavalent vaccine globally. And we are proud to launch the first generic of nanoalbumin-bound paclitaxel in India, which is Pacliol. We have got 4 R&D centers across the country with 100 scientists who are working day in and day out for developing the newer molecule for us. We have 1,500 plus patents filed globally and 460 that got the approval. We have given 3 approved US NDAs and 3 pending for approval and 23 under development. We have already developed C9 vaccines, and 25 vaccines are basically in the generic phase, especially for the rest of the world. We are leveraging alliances for growth in vaccines, and we are proud to have the collaboration with Russian Direct Investment Fund, especially for developing 1 crore doses for Sputnik 5, and the Intravac in licensed technology from Intravac Netherlands for production of the international polio vaccines, and then related the quality control testing for commercialization in India and other international markets. We continuously are working for alliances, and we are proud to have the association with Biotec, which has basically launched the Prasugrel tablets in the USA, and we are collaborating for research and development license and supply of paclitaxel protein-bound particles in USA, Canada, Australia, and New Zealand, and several other countries. We have collaborated with Biopharma Incorporation, and we launched tacrolimus and risperidone benzoate tablets in USA, and 4 more ANDAs filed with the USA. And Breckenridge Pharmaceutical, we just collaborated along with NATCO, especially for the development of azacitidine for US market. What I spoke that we have got the US approved dedicated oncology facility at Bati. We have got the capacity of 1.2 million vials production annually. And we are compliant with various international regulatory standards like US FDA and EU GMP certification, and we develop and deliver world-class affordable medicines. Especially in our hematology basket, we are proud to have dasatinib, dasaptan, azacitidine, our in-house product, azafab, and then we are the proud manufacturer and exporter of Boti Trust, a brand of Botisdonib. Especially for the patient support program, we have tied up with Core Diagnostic for providing one of the best testing, especially for the poor patient support with the BCR-ABL testing support program. We have a sponsored test with the subsidized pricing, and especially for a very poor class patients, we offer them the free of cost KD mutation and then BCR-ABL quantitative test. We extend our greetings and we extend our support for Mumbai Hematology Group, and we are really thankful to Dr. Agarwal for giving us this opportunity of introduction of Panacea Biotech. Thank you so much, sir.
Thank you, Mr. Shailendra. So good morning to one and all. Guest speaker this morning is Professor Soniya Nityanand from Lucknow. She is going to deliver the lecture on From Bones to Imaging to Repair, all one should know about myeloma bone disease. This webinar is brought to you by Mumbai Hematology Group, supported by Panacea Biotec and managed by Mice Ideas. I thank Mr. Shailendra Kumar Srivastava and their team from Panacea Biotech, Mr. Rajesh, Mr. Kalpesh and team from Mice Ideas, Executive Committee of Mumbai Hematology Group. Our chief guest this morning, Dr. Colonel Professor Prakash Chitalkar from Indore. Our guest speaker, Professor Soniya Nityanand from Lucknow. All our discussants were themselves eminent hematologists and medical oncologists from India, and you participants for sparing your Sunday morning. Our next weekend, Saturday, 7 p.m., we have guest speaker from Milwaukee, Dr. Binod Dhakal. He's going to speak to us on MRD in myeloma. Is it ready for the prime time? Next day morning, Sunday, 11:30 a.m. onwards, we have two speakers. Dr. Shaji from CMC Indore to speak to us on molecular diagnosis of marrow failure syndromes, to be followed by Dr. Regis Payfault de Letor from Paris, and he's going to speak to us on PNH and update on new treatments. To introduce our guest speaker, Dr. Soniya Nityanand. She's MD, PhD, FNASC, FASC. Director, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow. Former Executive Registrar, Sanjay Gandhi PG Institute of Medical Sciences, Lucknow. Former Professor and Head Department of Hematology at Stem Cell Research Center at SGPGI, Lucknow. She did her MD Medicine from King George Medical College, Lucknow, followed by PhD in Medicine from Stockholm, Sweden. She's Nodal Officer Hemophilia Program for the state of UP. In 1999, she established the bone marrow transplant program at SGPGI. In 2003, she established the first department of hematology in SGPGI. 2018, she established the world-class stem cell research center at SGPGI. She initiated DM in clinical hematology, postdoctoral certificate course in hemato-oncology, pediatric hematology, hematopathology, and postdoctoral fellowship program in BMT at SGPGI. She is fellow of two of the three national science academies, that is National Academy of Sciences, India, and Indian Academy of Sciences. She has over 125 research publications in peer-reviewed international and national journals. During her career at SGPGI, she successfully raised research funding of rupees 13 crores for 24 very important projects. Our discussants this morning include Dr. Akanksha Garg. She is Assistant Professor Hematology in BMT, Department of Medical Oncology at Gujarat Cancer Research Institute, Ahmedabad. Dr. Aditi Harsh Thanki. She is Consultant Medical and Hemato-Oncologist, Sterling Cancer Hospital, Rajkot. Dr. Abha Dubey, she is Consultant Hematologist and Hemato-Oncologist at Shelby Hospitals, Ahmedabad. Dr. Kripa Bajaj, she is Consultant Medical Oncologist at Indo-American Cancer Hospital Research Institute, Hyderabad. Dr. Ankita Sen, Hematologist and Hemato-Oncologist at Hamri Hospital, Salt Lake, Kolkata. Dr. Tejaswini Gudibande at Maulana Shah Medical Center, Narayan Health, Bengaluru. Dr. Gunjan Prasad from Department of Clinical Hematology in BMT, Apollo Hospital, Kolkata. Now it's time to have the Sunday quiz for the PG students. At the top, you have the email ID where you have to email your answer. mbagarwal1@gmail.com. Today, we will show you a clinical picture, a urine sample, and a peripheral blood film. These belong to a boy who is 18 years old, and he was brought with extreme pallor and gasping of short duration. You have to email name of the hematological disorder. Winner will be the fastest finger first. So now we'll show you the clinical picture, the urine sample, and the peripheral blood film. So the left side is the clinical picture. On the right side is his urine sample. That's the peripheral blood flow. So you will be emailing the answer to mbagarwal1@gmail.com. Now it's my proud privilege to introduce the chief guest of the day. The chief guest is none other than Colonel Dr. Professor Prakash Chitalkar from Indore. Colonel Dr. Prakash Chitalkar is Professor and Head, Department of Pediatric Hematology at Sri Aurobindo Medical College and Postgraduate Institute in Indore. He is medical and pediatric hemato-oncologist. He has served the Indian Armed Forces with distinction for 27 years. He pioneered the practice of bone marrow transplantation in the armed forces in the late 1990s and educated many armed forces physicians in India in medicine and oncology. He performed the first cord blood transplant in relapsed leukemia in Feb 1998 in RNR Army Hospital, Delhi. Since 2012, he has focused on the cancer among teenagers and young adults aged 15 to 29 and has created a national movement of oncologists who dedicate their services so that every young person with cancer must get the best chance of survival and also achieve his life dream. The mission of the national non-profit Teenage and Young Adult Cancer Foundation, TYACAN, which he helped in creating. He and his postgraduates are engaged in the research related to cancer awareness among school and college students in Western Madhya Pradesh, limited treatment abandonment in young persons, socioeconomic issues among young persons and caregivers, providing treatment and psychosocial support to young persons with hematological cancers and transplant-treatable hematological disorders in Western Madhya Pradesh. A curriculum for a fellowship in teenage and young adult cancer is under development at the foundation. The TYACAN Foundation's 10th annual meeting is scheduled next month on 25th and 26th of September 2021. With this brief introduction, it's my pleasure to invite Colonel Dr. Professor Prakash Chitalkar to inaugurate our webinar this morning and give us some words of wisdom. Thank you so much.
Hello, can you hear me?
Yes, Professor Prakash.
Thank you, Dr. Agarwal, sir, for your kind introduction. It is my great privilege to address this webinar as a chief guest this morning. And this is one among the chain of learning events organized with unfailing regularity by Dr. Agarwal and his team. And my sincere thanks to him for calling me as a chief guest. And it's certainly a singular honor bestowed upon me. Practicing medicine has been a great privilege, as I realized over 27 years in the military and in the unique moral environment that the armed forces gave me to alleviate the suffering of young soldiers, sailors, and airmen. However, more than the craft of medicine, I took the opportunity to hone my skills in expression, in ideation, and in pondering on the higher purpose of life. A few of these thoughts I'll share with you today. Mankind progressed from about 2000 years ago, starting as hunter-gatherers in the underbelly of Africa. And in the form of communication which sustained this primitive society was, you'll all be surprised, was actually gossip or myth. Primitive humans traversed the savannas of Africa and reached Asia, Europe, Australia with developing agriculture, settlements, and cities, all on myths and gossips. Cut to the rapid technological advances of the 20th and 21st century, and we are on the cusp of an information society, transforming into a world connected deeply with the internet. Artificial intelligence is likely in a decade or two to dominate every profession, and indeed overwhelm the very meaning of being human. Most people will be literally overrun by the machine learning, deep cortical thinking, and analytical algorithms. Traditional jobs as we know them, production, factories, will disappear and be replaced by robots and 3D printing. Traditional gossip, myths are already being replaced by GPS and Google Maps. Human beings will then be regarded or even regard themselves as carriers of information bytes, as mere vehicles of data and their personal attributes. Their genomes will be the property of large medical corporations. Free will, as we know it, will not remain free, and there will be algorithms to detect and to dictate our emotions, our likes, and maybe our dislikes. These algorithms will dictate what we speak in public, what we buy, what we want, or what we should seek in life. It is expected that the manufacturing sector, the information tech businesses, transports, and other businesses will be rapidly overrun by artificial intelligence. The healthcare profession is likely one of the last sectors of the economy to be taken over by algorithms. Algorithms are already taking over how a radiologist interprets an X-ray, MRI, or a CT scan. The octa-scan of retinal vessels can predict the likelihood of a heart attack in a patient. How even a pathologist interprets the nuances of a histopathology slide. Interestingly, if artificial intelligence overtakes doctors' profession, then nurses will be left in the field with skills which will be considered human, and if only for their practical dexterity and their visuospatial skills. Therefore, can we avoid or delay or even deny our decline as human beings from being the greatest creation of nature in evolution to the mere carrier of data in bits and bytes? The journey of mankind has been from the myths and gossips of antiquity to the all-powerful bits and bytes of today. But ladies and gentlemen, human suffering is no myth. As long as we bind our destiny to the suffering fellow human beings, as long as we use our emotions to understand another's emotions, we are likely to remain human and not digitally propped humanoids or homo deus. So I leave you with this thought, expressed with amazing insights in Yuval Noah Harari, who's a historian, his book, 21 Lessons for the 21st Century. Thank you very much. And I'll leave you for the intellectual feast back to Dr. Agarwal. Thank you so much.
Thank you, Professor Dr. Colonel Prakash Chitalkar. What a wonderful inaugural speech that was. I must clap. It was fantastic. I enjoyed listening to you. Thank you for sparing your time, being with us, honoring us, and what a speech. Fantastic. Thank you. Thank you. And now we are over to our guest speaker for the day, Professor Soniya Nityanand.
Professor Agarwal, Professor Chitalkar, who's the chief guest for today, Mr. Kumar Srivastava, Kalpesh and Rajesh, all the participants and all the discussants. A very good morning, and I would like to begin by thanking Dr. B Agarwal for again inviting me to deliver this tutorial today. It is amazing that every Sunday you have a session which I have a feedback from the students and other people in the hematology community that they are very extremely useful and have actually enhanced our learning and knowledge. I also would like to thank the MICE Ideas for being there for all these sessions and for many more sessions, and the Panacea group for sponsoring it. With this, I would like to begin my talk, which is on myeloma bone disease. I'm going to start my share my screen now. Is it visible?
Yeah, put it on a full screen mode, ma'am. Slideshow.
Yeah, it is in the full screen. Is it okay?
Yeah, good to go, ma'am. Yeah.
Yeah. So I'm going to talk from the basic pathology of myeloma bone disease to imaging and then to the management and treatment. So why is bone disease so important in multiple myeloma? Because approximately 80% of the newly diagnosed patients have bone involvement in the form of osteolytic lesions. So it's a very significant and high involvement in a disease. And these myeloma bone lesions are associated with skeletal related events. They lead to skeletal related events like bone pains, pathological fractures, vertebral collapse with spinal cord compression, hypercalcemia, and spinal cord compression. The involvement of the bone as a myeloma defining event, as an end organ involvement, has been recognized, and that is why the myeloma defining events are not CRAB, but SLIM CRAB, in which SLIM has been added, and M is for a bone lesion, MRI showing more than one focal lesion. So a little bit about the understanding of the biology of myeloma bone disease. This is very important because the drugs which have evolved for the treatment of myeloma bone disease and which are evolving have come out of an understanding of myeloma bone disease. If one doesn't understand the biology of myeloma bone disease, I think these therapeutic agents will not evolve. The bone remodeling, the bone structure is largely dependent on a very fine tuning between the bone stromal cells, normally between the bone marrow stromal cells, the stroma, the osteocytes, the osteoclasts, the osteoblasts, and some immune cells. The myeloma cells lead to an extensive apoptosis of osteocytes in the bone marrow, in the bones. The myeloma cells home into the marrow because of the interaction of the VLA4, which is expressed on the myeloma cells and which interacts with VCAM1 on the stromal cells. In the marrow, they produce a horde of molecules. One of the most important molecules is the receptor activation for NF-kappa-B ligand, RANK-L. The RANK-L is also produced by osteocytes. The osteocytes also produce RANK-L. Now, RANK-L binds to RANK on the osteoclast and leads to an activation of osteoclast. So there is enhanced activity of osteoclastic activation in the bone marrow, in the bones. Normally, this is regulated and antagonized by OPG. OPG antagonizes the RANK ligand and RANK interaction. However, the OPG is degraded by the syndicam-1, which is expressed on the surface of the myeloma cells. So you see that there is a tilt towards increased RANK-L and decreased OPG. So the ratio of RANK-L and OPG is grossly deranged, dysregulated, which is responsible for the osteoclastic activation. And this, because it was understood, there is a very powerful agent, a monoclonal antibody, which has come into clinical practice against RANK-L, known as denosumab. That is why the importance of understanding the biology of myeloma bone disease. So activation of the osteoclast, which will lead to bone destruction. On the other hand, there is a suppression of the osteoblastic activity. And osteoblastic activity is regulated by the WNT and the catenin pathways. These are inhibited by the soluble factors, a number of soluble factors which are produced by myeloma cells and osteocytes like DKK1, the Frizzle protein, the sclerostin. And therefore, there is a suppression of the WNT pathways in the osteoblast, leading to a suppression of the osteoblastic activity. So these are the 3-4 cardinal pathways which are responsible for myeloma bone disease. Along with that, a number of chemokines like CCL3, SDF, interleukins, annexin 2, etc. also lead to osteoclastic activation. There is an immune dysregulation of the Th17 cells, which also promotes activation of osteoclasts. So this is what cascades the myeloma bone disease, the increased osteoclastic activity coupled with both a diminution of the osteoblastic activity. So this is one bone disease where both osteoclastic activity is increased and the osteoblastic activity is diminished. So with this background of the biology of myeloma bone disease, we first begin as to how to detect the myeloma bone disease. And there comes in the role of imaging. And the importance of imaging in multiple myeloma is manifold. And it cannot, it cannot be undermined. It dictates the decision to start treatment. It's a myeloma defining event. It will distinguish a smoldering multiple myeloma to active myeloma and even predict the risk of progression from smoldering multiple myeloma to active myeloma. By imaging, you can diagnose myeloma bone disease as a cause of pain, neurological complication, and sites of potential fracture. Imaging is emerging as an important tool to assess the response to treatment, especially in non-secretory or oligosecretory myeloma, where the parameters for assessing response are limited. It goes without saying that imaging is one of the most important tools for detecting sites of extramedullary disease, and it will distinguish a solitary plasmacytoma from systemic disease, where the treatment approaches will be different. And it is emerging as a very powerful MRD monitoring tool to the extent that it is complementing the MRD monitoring by flow or NGS. So what are the imaging modalities for detecting for myeloma bone disease? We have the conventional skeletal survey, but have moved on to a low dose whole body CT. And then we have a whole body or at least axial MRI and an FDG PET CT. The imaging modalities evolved from morphological, where largely we were assessing lysis of the bone destruction, the lytic bone lesions. It's the skeletal survey, the whole body low dose CT, and the CT part of PET CT. But what is emerging even more is the functional imaging modalities, which is the axial or whole body MRI by a dynamic contrast enhanced MRI, which is based on differences in perfusion, and dynamic contrast, the dynamic weighted imaging. This is wrongly written. It is dynamic weighted imaging, where we gauge differences in the cellular density. And then PET CT. The imaging is used at diagnosis, as I already highlighted, in restaging and in post-treatment assessment of response, and finally in MRD. If we compare the imaging techniques, you'll see that most commonly used is skeletal survey because of the low cost and widespread availability. But the limitation is that it has a low sensitivity. And obviously it has no role in monitoring the therapy. In comparison, the low dose whole body CT has a much higher sensitivity than skeletal survey. It will detect at least an additional 25 to 30% of skeletal lytic lesions. And it has a very short acquisition time. At times, it can also detect extraskeletal lesions and a nodular oblique diffuse infiltration. No doubt it's a little more expensive than skeletal survey, but it is cheaper than whole body MRI and PET CT and has fairly low radiation exposure. Contrary to what most people think, it is not difficult to standardize low dose whole body CT. It just needs an extra program. And I think most centers in the country involved in myeloma management should standardize and go on to a low dose whole body CT rather than just a conventional skeletal survey. Then we have the whole body MRI, and if not whole body, at least the spine and the pelvis MRI. It's one of the most sensitive technique, and it very beautifully shows bone marrow infiltration. And as is evident from the SLIM criteria, it is important for differentiating a smoldering multiple myeloma from active myeloma. It definitely has a higher cost. And till now, it was thought that it's not a good tool for response assessment. But as we go down in my talk, you will realize that it is also evolving, especially the diffusion weighted MRI, as a very important tool for response assessment. The conventional MRI was not ideal because of the long persistence of the lesions. And then we have the PET CT, which has important prognostic implications. 3 or more focal lesions is classified as a high-risk disease. It is the modality of choice for extramedullary disease, and it has a very important role in MRD, in treatment monitoring, and in minimal residual disease determination of MRD. This is again very important. I'm going to show you why more and more literature is coming in for the role of imaging in MRD, but limited by the cost and the availability. So I will begin about imaging in myeloma by presenting a few cases. Case 1 is a 78-year-old woman who presented with chronic progressive right shoulder pain, limiting her joint mobility, and she was a farmer and engaged in heavy lifting. So this is what brought her to medical attention. Her shoulder showed advanced degenerative arthritis, but no lytic lesions. The lab test shows a normal CBC, calcium, and creatinine, a protein of 8.7 with an M band of 1.7, which was IgG kappa type of M band. The kappa levels were 8.61, the lambda was 0.63, and the kappa lambda ratio was 13.67. A bone marrow biopsy showed only 6% kappa restricted plasma cells, and the skeletal survey showed no lytic lesions. So what was the diagnosis? This is a 78-year-old woman with an M band of 1.7 grams per DL, only 6% kappa restricted plasma cells, no lytic lesions. And how will you proceed further in relation to bone imaging? I'm sure all of you must have thought of the answer. And the answer is that she had an MGIS. MGIS has a high incidence, about 3% in patients, in individuals who are more than 50 years and 5% in those who are more than 70 years. And this particular patient had high risk MGIS because she had an M band which was more than 1.5 and an abnormal FLC ratio, where the rate of progression with no risk factor in MGIS is 7.1% over 20 years. With one risk factor, it becomes 20%, and with two risk factors, it becomes 30%. So the International Myeloma Working Group recommends whole body imaging only in the high risk MGIS, obviously the non-IgM MGIS. And why a whole body imaging? Is to exclude any bone destruction. And the normal modality of choice would be a whole body low dose CT or a skeletal survey. And MRI has a limited role only if the whole body CT is equivocal, then one can think of doing an MRI. If it's equivocal, if it's negative, there is no. It distinguishes multiple myeloma related skeletal event from a benign cause, and it is also important for oligosecretory disease. So in this patient, this is the algorithm which has been the consensus, as per the consensus of the International Myeloma Working Group, where it shows that a suspected MGIS, obviously a non-IgM type, especially the high risk, as I said, a low dose whole body CT. If it is positive, then obviously you will treat as multiple myeloma. If it is negative, it does not, you just need a yearly follow-up for MGIS. It does not need a follow-up with imaging. And if it is inconclusive, then you subject the patient to a whole body MRI, which if positive, will be treated as multiple myeloma. So with this in the background, we did a whole body low dose CT in the patient, and to our surprise, we did find a pelvic lesion and an MRI of the lumbar spine at the L2 level also showed a lesion. So this labeled the patient as myeloma, and we treated the patient as myeloma. The next case. This is a 40 years old male who presented with a retroperitoneal mass. A CT-guided biopsy was suggestive of plasmacytoma. The IHC showed a diffuse expression of CD138, Vimentin, and CD45 weak. Negative for 20, pan-cytokeratin and CD3. Ki-67 proliferation index was 15 to 20%. The CBC was normal. The bone marrow was normal. The serum protein electrophoresis and immunofixation showed no M band. The kappa FLC was 137, the lambda FLC was 49.5, and the kappa lambda ratio was 2.76. And the skeletal survey showed no lytic lesions. So calcium 9, creatinine 0.7, hemoglobin 30, no bony lesions. No M band, but a kappa lambda ratio of 2.76. So what we did was, we did a PET scan. we had found a mass, there was an M band, and we did a PET CT. And that showed and confirmed a solitary pelvic mass. So do you think the PET scan was justified in this patient? The answer is like this. In solitary plasmacytomas in myeloma, solitary plasmacytomas, bone or extramedullary, the prevalence is 2:1, and the progression to multiple myeloma in 2 years for bony is 35%, and in extramedullary it is 7%. The objective of imaging is to detect additional osteolytic lesions and soft tissue masses. There is no real comparison of whole body MRI and PET CT. In bone plasmacytoma, MRI, because of its greater sensitivity for marrow infiltration, which though not a myeloma defining event, would prompt for exploring reasons for high bone marrow cellularity. For extramedullary plasmacytomas, it's PET CT. And the risk for progression or relapse in first 3 years is 14 to 38%. And then thus a yearly imaging is needed. Because this was a soft tissue mass which turned out to be a plasmacytoma, that is what drove us to do a PET CT. To look for any additional soft tissue masses, oblique osteolytic lesions. So this is the imaging algorithm for a solitary plasmacytoma as put forward by the International Myeloma Working Group, that if it is extramedullary, the imaging of choice is a PET CT, and if it's bony, you think of a whole body MRI. And a yearly follow-up with the original technique for at least 5 years because of the high rate of relapse and progression. The case 3 is a 62-year-old gentleman who presented with fatigue and generalized body aches. The lab test showed a normal CBC, calcium, and creatinine. However, the serum protein was 10.2 with an albumin of 4.7, an M band of 5.7, which was IgG kappa. The kappa was 48, the lambda was 5.4, and a kappa lambda ratio of 9. The biopsy of the bone marrow showed 16% kappa restricted plasma cells. Skeletal survey, no lytic lesions. So an M, no other crab features, but an M band of 5.7 and an altered kappa lambda ratio, 16% restricted, 16% kappa restricted plasma cells. But no lytic lesions in the bone, normal calcium, creatinine, hemoglobin. So what is the diagnosis and how should we proceed further in relation to bone imaging? So obviously this is a patient with smoldering multiple myeloma. And as I highlighted in the beginning, that you have to distinguish a smoldering multiple myeloma from active multiple myeloma. Because active multiple myeloma has to be treated immediately. So we subjected the patient to a low dose whole body CT, which was normal. So the next question is, what next should we subject the patient? Should we subject the patient to any other imaging? That is PET CT or MRI of the spine and pelvis? Or is a low dose whole body CT enough to say that the patient has smoldering multiple myeloma and there is no need to go on further? Or should we do further imaging, and what should be the further imaging? So as I had already highlighted to you earlier, when I compared the different modalities, that the highest sensitivity for early lesions is MRI. So definitely, it's much above the whole body low dose CT. So this is the algorithm for a smoldering multiple myeloma, and this is important because it's a major treatment decision at this point of time. So you can begin with the low dose whole body CT. If negative, then you still will take up the patient for an MRI, or if inconclusive. And if positive, straight away, label the patient and treat as multiple myeloma. If negative or inclusive, you should follow it up with an MRI, whole body or at least an axial MRI. If negative, then a yearly follow-up with MRI. However, if positive, with more than one equivocal focal lesion, treat as multiple myeloma. And if there is an unequivocal focal lesion, then again, you will have to follow up and see for an increase in the size or the number of the osteolytic lesions. So in smoldering multiple myeloma, one goes all the way out to look for the slim criteria, that is for a bony lesion. So we come to case 4. This is a 66 years old male with a right pelvic mass. The FNAC was suggestive of a plasmacytoma. The bone marrow showed 18% plasma cells and an M band of 3.7, which was IgG kappa. The kappa was 42.6, lambda was 10, kappa lambda ratio was 4.2. Skeletal survey showed no other lytic lesions. Calcium was 9.2, creatinine was 0.9, hemoglobin was 13.8. But there was a bony plasmacytoma, 18% plasma cells, and an M band of 3.7. So obviously, this is a patient of myeloma. The algorithm which has been put forward for any suspected multiple myeloma is, as I began by saying, you can begin with a low dose whole body CT, and if not available, then a PET CT, which if positive, straight away treat as myeloma. If negative or inconclusive, go on and do an MRI, which if negative and there is no other myeloma defining event, then you have to do a yearly follow-up as you would do for a smoldering myeloma. But if positive, then the same thing. If more than one lesion, it's myeloma. If it's one unequivocal lesion, you follow up with serial MRIs on a yearly basis for increase in size or numbers or osteolytic activity. So this is these are not rigid protocols, these are not rigid algorithms, but this is the kind of way that one proceeds in a logical and scientific manner for imaging in multiple myeloma. This is one area that I wanted to cover today because this is something which is evolving very fast, is the functional MRI, especially for evaluation of response to therapy and for MRD. There are two ways of going about a functional MRI. One is the dynamic contrast enhanced, which evaluates differences in perfusion, and the second is the diffusion weighted imaging, which evaluates differences in cellular density and puts forward what is known as a quantitative analysis by ADC, apparent diffusion coefficient. This is one thing that I wanted to highlight, because in normal marrow, you have fat spaces and a few cells. So the water content is low. The diffusion weighted imaging, the coefficient is dependent on the ratio of the fat to the water content. So the fat is more, the cells are less, the water content is low, so the ADC is low. As the marrow gets infiltrated by plasma cells, the water content increases, the fat decreases, the ADC increases. Now what happens is that the moment the plasma cells are very high, I'll come back to this later, the plasma cells increase, the water content increases, and the ADC keeps rising. You treat. Initially with treatment, there'll be an apoptosis of the cells, which will again be water-laden. So in the early response to therapy, the water content will increase, the apparent diffusion coefficient will increase because of the apoptotic cells, and then it will start coming down. So this brings us to the point that normally you have a low normal ADC because there is more of fat and less of water. The ADC will be increased in the focal lesions, which will be teeming with cells. As I said, after therapy, initially the ADC will increase because of the apoptosis of the cells and then decreases. And finally, it will keep decreasing in a diffuse manner. And it will remain unchanged in non-responding patients. So this is MRI evolving as the functional MRI evolving as a very powerful and complementary tool for assessing response to therapy. I'll come back to it again. Okay, just a little background in myeloma. We all know that there is an initiating genetic event. I mean, this is the genomics of myeloma. And myeloma is a nice disease to study genetically because it's a continuum from MGUS to myeloma to smoldering multiple myeloma to myeloma to advanced myeloma. And one begins with an initiating genetic event which leads to MGUS, which can stop there. But if there is acquisition of driver events, additional genetic events, it will progress from MGUS to smoldering to multiple myeloma. And as more and more driver events kick in, it will lead to advanced myeloma. So in advanced myeloma, the lesions will have clones, multiple clones with diverse genetics in them, with diverse genetic abnormalities in them. So this is what is called as the spatial heterogeneity. You look at this PET CT. A biopsy has been done from the left iliac crest, as we normally do. The gene expression profiling shows that it's a low-risk disease, hyperdiploid, translocation of MYC and BRAF mutation present. But this patient also had a focal lesion at the fourth lumbar vertebra, and it was biopsied. And it showed, to the utter surprise, the gene expression profiling showed it to be a high risk. It was non-hyperdiploid, deletion 1p12, deletion 1p32, deletion 13q, and a biallelic TP53 deletion. So spatially, you have, it seems, or it's evident that there are two different clones of cells. One which is low risk with this genetic background, and one which is high risk with this genetic background. So in this study, What the investigators have done is that in about, I think, 83 patients, they have taken paired samples, one from the iliac crest and one a CT-guided biopsy from another lesion. And then they have seen the gene expression profiling of these two biopsies and their concordance or their discordance and the impact on the survival. So when the gene expression profiling from both the biopsies was low, this is how the Kaplan-Meier survival curve looked like. When the gene expression profiling from both the biopsy samples, these are paired samples from one individual and a total of 83 individuals. When the gene expression profiling from both the samples showed a high risk, this is how the survival curves were. But now you look at this blue curve. Here, the gene expression profiling showed that from the one biopsy site, it was low, but from one biopsy site, it was a high risk. And even if it is a high single biopsy, even from one biopsy side, if the risk is high, it follows this curve, how much it affects the overall survival. This just shows that our biopsies, conventional biopsies from the iliac crest may not be enough to predict the outcome in these patients. A continuation of this study, seeing more about this, that the more heterogeneous is the spatial, the more is the size of the lesion. A focal lesion which is less than 1 centimeter, more than 1 centimeter, more than 2.5 centimeters. The unshared mutations are higher is the focal lesion size. So spatial heterogeneity, the heterogeneity increases with the growing size of the focal lesions. So it's, the myeloma biology is quite complex. So what is now being advocated, there are a lot of studies, this is an area of intense research, is the combination of flow cytometry and the whole body functional imaging. That is diffusion weighted MRI and PET for monitoring MRD in myeloma. So the study, which was published in Leukemia 2019, shows that it took newly diagnosed and relapsed patients who underwent total treatment or a salvage if they were in the relapse setting, and a complete response was determined by diffusion weighted MRI, PET, and the MRD by flow. And here you can see that there is a lesion which is lighting up both on PET CT and the diffusion weighted MRI. So first of all, what the study showed, that this is for diffusion weighted MRI. If there are no focal lesions, this is how the survival curves will look out. And if there is a restriction, MRI restriction, this is how the survival curves will look like. But this is again no focal lesion. This is focal lesion on diffusion weighted MRI and focal lesions on PET. So the first thing that tells us is that focal lesions have an impact on survival. So the need to pick up residual focal lesions by imaging, this is what it brings us to. That just mere doing an MRD analysis from the bone marrow iliac crest is not enough. It will probably be the tip of the iceberg. One should look in follow-up for focal lesions by a diffusion weighted MRI and or PET. And this is what is interesting, that if actually the patients can be categorized into 3 categories, where they are MRD positive and imaging positive, 12%, the most poor group of patients. MRD negative and imaging negative, 36%, the most patients will do the best. But what about this 52% group, where there's a discrepancy between the MRD and imaging? So you have one group where MRD here I mean by flow, is positive, but imaging negative, 40%, but another 12% where the MRD is negative by flow, but positive by imaging. So this is how the curves look if you only look at MRD by flow. These are survival curves or progression-free survival if MRD is negative, and progression-free survival if MRD is positive. But now you come here. This is again a double negative. And this is MRD positive, but imaging negative. But look at these 2 curves. Irrespective of MRD, if the imaging was positive, then these 2 groups are for imaging positive patients. The survival curves are quite poor. So this is what I want to take home messages, that imaging is going to evolve as a very important tool for MRD assessment. And these are some of the conclusions that I wanted to bring out. So it's a malignancy which is characterized by a spatial heterogeneity. And I think this is what is responsible for relapse even in an MRD negative patient. And therefore the whole body functional imaging will be complementary for monitoring MRD. And it's shown very beautifully by these studies that the diffusion weighted MRI detects the prognostically relevant residual focal lesions. In fact, it detects more residual focal lesions than PET. And the dual approach using a diffusion weighted MRI and PET is the most sensitive approach. And that group of 12%, which were MRD negative, but imaging positive, 12% in newly diagnosed multiple myeloma patients, increases to almost 50% in the relapsed setting. That is MRD negative by flow, but imaging positive. That group becomes 50%. That's why even more important, the role of this functional whole body imaging for MRD in a relapsed setting. So a combination of MRD diagnostics and functional imaging is likely to improve the prediction of outcome with double negativity and double positivity, defining groups with excellent and dismal progression-free survival respectively. Okay. So the validated points, this is a nice article in Blood, which has very nicely brought out that the validated points for imaging in multiple myeloma are novel techniques. Imaging techniques are more sensitive than skeletal survey, especially to distinguish a smoldering myeloma from multiple myeloma. And at least whole body low dose CT is a minimal requirement for detection of lytic lesions. MRI is the best modality as of today for assessment of bone marrow involvement, and PET CT for extramedullary disease. And focal lesions, as I brought out, do display a prognostic significance for progression-free survival and overall survival. And functional imaging techniques are now evolving for assessing the response to therapy. Currently, of course, PET CT is used to evaluate MRD. And MRD by NGS or by next generation sequencing or next generation flow and PET CT are complementary. Okay, I'll come to a little bit about the treatment of bone disease in myeloma. The treatment is essentially medical, surgical, and radiation. Medical, one should not forget, a lot of these anti-myeloma drugs, especially the proteasome inhibitors, have an effect on bone disease. You know, they enhance the viability of osteocytes. I began by telling you in the biology of myeloma bone disease, there is an extensive apoptosis of osteocytes, but these proteasome inhibitors, they enhance the viability of osteocytes, 1, and 2, they upregulate the beta-catenin pathway, which promotes osteoblastic activity. So bone disease is not just to be treated with bisphosphonates, but also the anti-myeloma therapy has an important bearing. So the second medical management is bisphosphonates, then novel agents, then pain management, and then of course we have the surgical management in the form of vertebroplasty, open reduction and fixation, and radiation therapy. So bisphosphonates. Bisphosphonates should be given to all active myeloma patients. You don't need to demonstrate bone disease. Any patients who's labeled as active myeloma patient should get bisphosphonate. You should give it for myeloma-associated hypercalcemia, where zoledronic acid is superior to palmidronate. It is recommended for a low-risk smoldering multiple myeloma, MGS, solitary plasmacytoma if there is osteoporosis, at a dose which is recommended for osteoporosis. However, for high-risk smoldering multiple myeloma or a smoldering multiple myeloma with one focal lesion or with equivocal findings, you will give it at a dose which you would give for symptomatic multiple myeloma. As we all know, zoledronic acid is given 4 milligram over 15 minutes every 3 to 4 weeks, and palmidronate is 30 versus 90 over 2 hours. 30 milligrams and a 90 for 4 hours, 30 for 2 hours and 90 for 4 hours, every 3 to 4 weeks. And dose adjustment for both in renal impairment, you only give it if the creatinine clearance is more than 30. And for 30 to 60, one has to reduce the dose of zoledronic acid and chlordronic acid, which is not used in India, and an extended duration for palmidronic acid. Means 30 milligrams instead of over 2 hours, would give it over 4 to 6 hours. This is just which one to use. So this is the MRC Myeloma 9 trial, which showed zoledronic acid versus chlordronate. And the primary endpoint was a progression-free survival, overall survival response, and secondary were the skeletal related events, the time to the first skeletal related event, and the overall incidence. And the 9 trial did show that the zoledronic acid had a survival advantage, overall survival. So people where both drugs are available would probably choose zoledronic acid over chlordronate. And the skeletal related events were also less in the zoledronic arm in comparison to the chlordronate. And when we talk of skeletal related events, these are defined as vertebral fractures or other fractures or spinal cord compression, which require or a requirement for radiation or surgery to the bone tissue or appearance of new osteolytic bone tissues. The duration is normally 12 to 24 months, and I'll tell you why this range, if well tolerated. However, if no VGP, at least no VGPR has been achieved, you can even continue it indefinitely. This is a physician-driven decision. They can be reinitiated at the time of the biochemical relapse. And why I said 12 to 24 months, conventionally it's 24 months, but now people are even giving it for 12 months with the introduction of novel quadruplet combinations, which result in durable remissions of the disease. It has been very nicely shown that after an autologous stem cell transplant, if you consolidate with bortezomib, there is a favorable effect on bone metabolism, as I told you, and a low skeletal related event incidence, even in the absence of bisphosphonate co-administration. This has been shown in 2 prospective studies, because it itself, bortezomib itself, has the bone a bone forming effect in myeloma. The adverse events, as we all know, are hypocalcemia, hypophosphatemia, and therefore you need calcium supplementation, renal impairment, both by zoledronic acid and by palmidronate. Zoledronic can lead to acute tubular necrosis, and palmidronate can lead to glomerular damage, and therefore a monitoring of albuminuria when you give palmidronate. And of course, osteonecrosis of the jaw, which can be seen in 1 to 10% of the patients with a higher risk with zoledronate. And one has to take preventive measures, oral hygiene, avoidance of dental procedures when one puts patients on these 2 drugs, on the bisphosphonates. And at least a 6-month peri-procedural drug holiday for elective invasive dental procedures and a prophylactic antibiotic. And this is how typically an osteonecrosis of the jaw will look in a patient who's on bisphosphonate. From here, I move on to the last aspect, which is denosumab. I began by telling you that there is an intense hunt for new drugs in multiple myeloma, and one of them has been denosumab. It's a human monoclonal antibody to the rank ligand that binds with a high affinity and specificity to both the soluble and the cell membrane form of rank L. You know, rank L, I had shown that it is produced by myeloma cells and other cells, and it binds to the rank on osteoclasts and leads to osteoclastic activation, and therefore the rank L-rank interaction is blocked by denosumab, and the osteoclastic activity is thus inhibited. And it was initially approved for osteoporosis and for metastatic bone diseases, but in 2018 it has been approved for multiple myeloma. And it has been shown to be superior to zoledronic acid for prevention of skeletal related events in 3 pivotal randomized trials, phase 3 trials. And this is the latest trial which has now got published of denosumab versus zoledronic acid, to 2009-0482 trial, an international double-blind study. And it was shown that at least it's non-inferior to zoledronic acid in delaying the time to the first skeletal related event. And a post hoc analysis, however, showed that it was actually superior for delaying the time to the first SRE. And the secondary endpoints have shown, though the data is still immature, that there is a benefit of 10.7 months for the median progression-free survival. So it appears to be a promising agent. The problem with all these drugs, agents, is whether it's bisphosphonates or denosumab, that they will prevent a further bone loss. But what bone loss has already occurred remains. And therefore, a continuous hunt for newer regions. We want that the loss which has already, we just don't want to stop further bone loss or bone lytic lesions, but those lytic lesions which have occurred, we want them to get repaired also. So anyway, there are novel agents which are being explored for bone disease, and all of them are dependent on understanding the biology of multiple myeloma bone disease. As I've already highlighted, you have bisphosphonates and denosumab. You have the proteasome inhibitors, the immunomodulators. As I had told you, IL-17 perpetuates the osteoclastic activation, so anti-IL-17. But the others which are evolving are the activin A antagonist, which is sotatercept. Then you have anti-DKK1, anti-sclerostin, anti-TGF. These are some which have come into clinical trials. Anti-IL-6, monoclonal antibody. So in the years to come, I hope some of them go beyond clinical trials and come into clinical practice. So local radiotherapy, very simple, very helpful for painful bone lesions, spinal cord compression, either as an aid craze, single fraction, as a palliation. Sometimes it helps very beautifully for localized painful bone lesions. But multiple fractions over 4 weeks for recons when you give it as a therapeutic dose. As a 30 grade, 20 fractions, 4 weeks, or you give it as 30 grade, 20 fractions, 2 weeks. And long course, multiple fractions for spinal cord compression. A word on the osteoporotic vertebral fractures. Here you can see the image of 2 osteoporotic vertebral fractures due to multiple myeloma. We have what is known as the technique of vertebroplasty and kyphoplasty, where the vertebra is stabilized and by injecting cement into the vertebra. And in kyphoplasty, you first do a balloon dilatation of the vertebra and then inject the cement. And there is a significant relief of pain with increased mobility, reduced analgesic requirement. And the most important is that it imparts a stability to the spine. The complications if done by a trained personnel is less than 10%. And therefore, it's a procedure which is being done more and more now by interventional radiologists and in some institutes, even by anesthetists. Corticosteroids, if you have nothing else, at least give corticosteroids. Corticosteroids, radiation, these are very commonly available. Powerful tool for bone pain relief, high anti-myeloma activity, particularly effective for bony pains, neuropathic pains, and spinal cord compression. Patient comes to you with paraparesis, it's an emergency in hematology, give high dose corticosteroids, and then take up the patient for radiotherapy or a laminectomy. This is a beautiful picture of a vanishing spinal cord compression because of a rapid response to dexamethasone monotherapy. If you've seen, these are 2 large osseous vertebral plasmacytomas impinging on the spinal cord. The patient was given high doses of dexamethasone, and 36 hours later, you can see that there's almost a disappearance of these masses. So that's why I called it as the vanishing tumor syndrome. So in conclusion, I would like to stop here that myeloma bone disease is a multidisciplinary approach for the diagnosis and management is needed in myeloma bone disease. This phosphonate therapy plays a pivotal role in the medical management, and anti-myeloma therapy, including novel agents, which are the proteasome inhibitors and IMiDs, also have an important adjuvant role in the disease management. And percutaneous vertebroplasty or balloon kyphoplasty are also important components. And including radiotherapy should be considered early in patients with spinal involvement to prevent the long-term complications. Thank you.
Thank you, Professor Sonia, for that lovely comprehensive review of the myeloma bone disease. It was very, very educative and wonderful to listen to you. Before we take up the question and answer session, I will just give the answer to the quiz and the winner's name. Okay, so the quiz this morning was that you were shown a clinical picture, one urine sample and a peripheral blood film of a boy aged 18 years who was brought with severe pallor and who was virtually gasping. We were shown this tongue, which I think almost all of you have picked up that he has got icteric tongue. And you also picked up that there was a gross pallor and that the urine was very dark, probably hemoglobinuria. So far, I think almost all of you were correct. Peripheral smear reading has been correct by only 11 out of you. What you see over here is now the abnormality is marked by these arrows. And the red arrows show you what is called blister cells. The blister here and here. And the green arrow is showing you the bite cell, as if a bite has been taken out of the red cell. So there are few of those bite cells, many of the blister cells. And that was diagnostic because you get this in G6PD deficiency. So this peripheral smear is diagnostic. It's important for you to understand this because in active hemolysis, your G6PD, even quantitative assay may come normal. And you may miss the bus if you're not carefully looked at the peripheral smear. And many, large number of you have answered all other causes of hemolytic anemias. Plenty of causes: cold agglutinin disease, autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, and so on. The number of people who have answered that overshadow the one who have got the G6PD correctly. Now, these are the people who got the answer correctly. Total 11 got it correct. 10 of them are here. In this order: the Dr. Ramesh B, Dr. Indrani Karmako, Dr. Krishna Ratnam Kanan, Dr. Sailesh Bombarde, Dr. Naveen Tamboli, Dr. Naveed Tamboli, Dr. Humaira Nazneen, Dr. David V, Dr. Satarupa Mahapatra, Dr. Yatindra Parashar, I'll come back to you, and Dr. Danushka Disanaike. Dr. Yatindra, you described everything, but you didn't give the diagnosis. You described that there is icterus, there is pallor, there is hemoglobinuria, there are blister cells, bite cells. You didn't write G6PD. So you are partly correct. Anyway, that does not matter. You are very close. The winner is one of our discussant today, Dr. Gunjan Prashad. So congratulations to you. She is from Department of Clinical Hematology, Bone Marrow Transplantation, Apollo Hospital, Kolkata. So heartiest congratulations to you. You will get your prize amount, and thank you so much. Now we will go to the question answer session, and we'll begin with our faculty who are here. Request all of you to open your videos and please keep it open if possible throughout the QA session. We begin with Dr. Akanksha Garg.
Yeah, thank you, sir. A very good afternoon, ma'am. That was a fabulous talk, and it's always a pleasure listening to you. So I have two questions. The first question I would like to ask you that in a resource constraint setting, how would you advise to incorporate imaging for the assessment of monitoring of the response to myeloma therapy in patients? So that is my first question. And the second question is that in patients where the creatinine clearance is less than 30 ml per minute, which bone modifying agent do you prefer and why?
Okay, nice to see you, Akanksha. And it's good to have you on board here. Akanksha has been my DM student, so I always am delighted when she comes on board, And she's done outstandingly well in her professional career. So I'm very proud that she's been my student. So answering your first question, that this is in a resource constraints, with resource constraints, I think you asked that what would be the modality of choice for monitoring, imaging modality of choice for monitoring the disease status. So answering the first question, that as of today, apart PET-CT is an imaging modality for monitoring the disease response, and it would be complementary to MRD assessment by flow cytometry. But there is no compulsion, and it is not categorically in guidelines that you have to monitor by imaging modality 2. I think the best is if you can monitor by a multi-parameter flow cytometry for MRD, which now has a role at different time points in the treatment of myeloma. That should be enough. If there is no resource constraints, then a PET-CT would be complementary. As I brought out, that more and more literature is coming in, more and more data is coming in, where focal lesions have a bearing on the outcome, more than 3 focal lesions. And if the focal lesions don't regress on imaging, you're just biopsying the iliac crest, but with PET-CT, you will pick up focal lesions other than of the iliac. Iliac crest is only tip of the iceberg. Then you do a PET-CT. But if there are constraints of resources, then for MRD, for response, multi-parameter flow cytometry would be a good option if patient can afford, and if there's availability, it can be supplemented with PET-CT. What was your second question, Akanksha?
Ma'am, the second question was that patients who have a creatinine clearance of less than 30 ml per minute, which bone modifying agent do you use?
Yeah. So above 30, as I told you, that you can only, you have to modify even zoledronic acid and palmidronate. And you should modify the doses and the time duration, which I brought out. The only option left is denosumab. And much more literature is even needed in denosumab. So denosumab is even below 30, even denosumab is that it's catchy to use denosumab also. But probably it will be relatively safer, and if the patient can afford, than zoledronic acid and palmidronate.
Thank you, ma'am.
Thank you, Dr. Akanksha. Dr. Aditi. Unmute yourself, Aditi.
Good evening, ma'am. My first question to you is, ma'am, what is the role of bisphosphonates in solitary plasmacytoma of bone?
So if it's an osseous solitary plasmacytoma, as I told you that, you have to, if it's a plasma, let me begin by being a little more basic. If it's a plasmacytoma with just, an extra osseous, which means an extramedullary plasmacytoma, a soft tissue mass, and there is an associated osteoporosis, you can give a bisphosphonate at a dose that you would give for osteoporosis. But if there is an osseous plasmacytoma with bony destruction, and there is a place for giving a bisphosphonate.
So the duration will be same as in multiple myeloma?
No, it will not be the same, because if it's a solitary osseous plasmacytoma and you are judiciously following up the patient, you can get away by giving the bisphosphonate for 6 months or 12 months. You don't need to give it for 24 months.
Okay.
Absolutely no.
Thank you, ma'am. And the second question was, ma'am, how do you choose the treatment, local or systemic, for multiple plasmacytoma of bone?
Okay. So if you have multiple for multiple plasmacytomas, you mean more than 2, I think?
So does the number 2 or more, do you choose?
So you should, it's very difficult to give local therapy for multiple plasmacytomas. They have a poor bearing on the outcome of the disease. So it would be good to treat them systemically, as you would treat a multiple myeloma patient. Extramedullary disease and, these plasmacytomas have a very adverse prognosis, especially if multiple.
Okay, I just was going through some literature and they had mentioned 2 lesions you probably could get away with only local treatment.
Absolutely. So more than 2, yeah, absolutely.
Okay, ma'am.
One more? You have another question?
I had one more question.
Please go ahead.
Ma'am, there is a CalGB study in which they have used in myeloma patients also lesser frequency of bisphosphonates every 3 monthly.
Yes.
From the beginning. So do you recommend that, or it should be?
There is data that, again, it's physician driven, and there is study where they've shown that zoledronic acid you can give even 3 monthly, especially after that initial phase of 12 months, you can give it 3 monthly. I still give it monthly. And, again, I give it for 24 months. But as I was telling you now, with 4 drug combinations, which themselves have an anti-myeloma bone effect, you can even give for 12 months. Because depth of response with these multiple drug combinations.
Sure. Thank you. Thank you.
Thank you. Dr. Abha?
Thank you, ma'am, for the extremely informative lecture. My question is, ma'am, in the second case that you mentioned with the retroperitoneal mass, with the solitary retroperitoneal mass, would you be observing this patient, this mass, as long as it is not causing any problems, or would you like to treat it as soon as it is resected by means of maybe radiation or surgery?
Yeah, so we would like to treat it, 1, 2, definitely treat it, and 2, as per imaging, if there are no other masses, we don't stop there. We do follow up these patients very closely for any relapse or occurrence of new lesions.
Okay, and my second question, sorry, ma'am. Yeah, please continue.
Yeah,
okay. And my second question is, how do you manage the myeloma-associated coagulopathies, especially if it is not associated with any apparent bleeding? For example, we might encounter,
Yeah. So myeloma-associated coagulopathies do occur because of the paraprotein, and you treat the basic disease, which is the myeloma. And as you said, if they're not associated with bleeding, so you're not directing the treatment of the coagulopathy, but you're directing the treatment of the paraprotein. And as the levels come down and disappear, the coagulopathy will get corrected.
Sure. If I give an example of a personal case, I had this patient who had just diagnosed with multiple myeloma. He had a raised APTT, which was considerably raised. However, there was no bleeding. So if at all in such a patient, I would like to do a bone marrow examination, which is a part of the diagnostic workup. Do you think I need to correct the APTT, or I could, just...
Yeah, you could just go ahead and do the bone marrow and give a compression after that.
Sure. That is what I did. Okay. Thank you, ma'am.
Thank you, Abha. Dr. Kripa?
Thank you very much, ma'am, for the wonderful talk. It's just a continuation of all my other panelists who have discussed already. My first question is the case you presented, the first case, MGUS. This patient got detected with single pelvic lesion. Later, MRI spine showed another lesion and he got treated subsequently. Is it the same, the guideline showed low dose CT if it is positive, then to treat as multiple myeloma, if inconclusive, then to go for whole body MRI. This isn't inconclusive, like whether to go for the MRI whole body or PET CT at this scenario, ma'am. Because no, it's a pelvic lesion, the pelvic lesion. So it's a very, whether to go for MRI or PET CT.
Yeah. So actually the modality, imaging modality that was, we could have just stopped at the It's actually, I like that question because, I was hoping someone would ask, because one should have just stopped at the low dose whole body CT. We picked up a lesion, and that was enough to show it was a lesion, and we knew that this patient has a lytic lesion on CT. But since it was a single lesion, we knew that we were in the direction of a myeloma in this patient. And that's why we went in and did an MRI. And we picked up another lesion on MRI in that patient. So it was more than one lesion, and there was no doubt that this patient had to be treated as active myeloma.
Okay, ma'am.
So one lytic lesion, you could have just stopped, But because it was a single lytic lesion, we decided to do another imaging, and we managed to pick up another lesion.
Why not PET CT in this case, ma'am? Why MRI you have chosen? Because it's a pelvic lesion. The benefit, why you have chosen MRI rather than PET CT?
MRI is good for spine and pelvis, and you don't need to do a whole body MRI. You can get away by just doing an axial MRI, which is the spine and the pelvis. And as of today, MRI is the most sensitive imaging modality for picking up lesions in multiple myeloma. Yes. You could do PET CT also. As I said, there is no categorical rule on it, but MRI being the most sensitive, and you want to be on a firm ground for treating a patient as active myeloma.
Yes, ma'am. Ma'am, the same question one of my panelists has asked. The lower frequency of zoledronic acid, ZMARC study as well as CalGB, they're showing a very good evidence of low frequency and long duration, like 4 years, up to 4 years. And what's your take on it, ma'am? You want to give it monthly for 2 years, 1 year, or how do you choose to give low frequency or a frequent dose of zoledronic acid?
Yeah, so there are no guidelines for choosing 3 monthly versus monthly, but data has shown that 3 monthly may be as effective as monthly. But as of today, there is no strong recommendation for 3 monthly. So again, it's a physician-driven decision. So if you ask me, I will give it monthly. I will give it for at least 12 months. If in 12 months I get a stringent CR, then I will just taper it off by giving it the next dose after 3 months for maybe 6 months, and then 6 months for another dose, and then stop it off and restart it if there is a relapse. Even at a biochemical relapse, I will restart it.
In ZMARC study, they have done a baseline assessment of NTX. Would you choose based on the number of lesions, skeletal lesions, or just you'll go by the response? The frequency of zoledronic acid.
3 monthly interval, you say?
Yeah, ma'am. If ever the baseline ZMARC study, they have assessed NTX levels and suggest of increased osteoclastic activity. Based on that, they have taken 3 monthly versus monthly. Apart from the thing you have told, the response, will you see the number of bony lesions as well in the baseline to choose the frequency, or
no,
I don't take a monthly?
And the decision for stopping it will depend on the myeloma response, by the standard criteria for myeloma response, especially a stringent myeloma response, not by the number of lesions.
Yes, ma'am. Can I ask one more question, sir?
Sure.
I have one question. Yeah. Ma'am, the denosumab, ma'am, Raje et al. Have published excluded less than creatinine levels 30 ml. And 30 to 60 ml also, they have seen a lot of hypocalcemic events in denosumab arm. So usually in breast cancer or any prostate cancer, whenever there is a rise in RFT, we try to give denosumab rather zoledronic acid. Here, giving in altered RFT also, it's not so benefiting. It's showing increased hypocalcemic events, and one study has shown a detrimental effect of denosumab compared to zoledronic acid. So different studies are giving a different output. Right. And recently, one study, they have yet to conclude less than 30 ml of creatinine clearance denosumab. What's your perspective about usage of denosumab in multiple myeloma, ma'am?
Yeah. So first thing, it's an expensive drug, and I work in a government hospital where patients are really not able to afford. So I fully agree that even in going to Akanksha's question, that in creatinine clearance, which is less than 30 ml, even denosumab is not completely safe. Obviously, you will not give palmitronate, you will not give zoledronic acid. They are completely unsafe in less than 30. And between 30 to 60, I said you have to modify the dose and the duration. But with denosumab also, that's a gray zone area that is it really safe to give in a creatinine clearance less than 30. But as of today, apart from the anti-myeloma drugs, we really don't have any other drug for myeloma bone disease. So one can think of giving it very carefully with strict monitoring for the renal parameters in less than 30. But a lot of investigators, a lot of clinicians will avoid denosumab even with a creatinine of less, with a creatinine of less than 30, they will not give it. And personally, if you ask me, I have not really used it in patients with a creatinine clearance less than 30, but I would be very careful. I would be skeptical about using it.
Thank you so much for your inputs.
Thank you, Kripa. Dr. Ankita.
Thank you, ma'am, for your excellent talk. Ma'am, I have two questions. One of them is related to denosumab, the newer agent. Though I've not used it personally, ma'am, like you said that the results are yet to be seen regarding its promising use. But for how long should we use denosumab in patients? Like for zoledronic, you said that it could vary between 2 years to 1 year. So for denosumab, do we have a set time limit for usage?
So I think what you're asking, Dr. Ankita, is the duration of therapy with denosumab. No? That's what you're asking? Okay. So there are no guidelines and for the duration of therapy in denosumab. Like for zoledronic acid, the guidelines are fairly clear. But what is very important to understand with denosumab is that when you stop it, there is a rebound phenomena. Suddenly, there is a widespread osteoclastic activation. And in fact, it can deteriorate the myeloma bone disease on abruptly stopping it. So there is a recommendation that you give a bridge with at least one injection, if not 2 injections of palmitronate. When you think of giving when you think of stopping denosumab, that is very, very important. And the duration is not very clear, whether it should be the same as for bisphosphonates, that is 2 years or 12 months, that is still not very clear. But a lot of people are using denosumab more in a setting where there is a renal impairment and they want to avoid the bisphosphonates. So I think if the renal functions improve with anti-myeloma treatment, then one is on a sounder ground to start the bisphosphonates. But it's good you brought this out because one should never abruptly stop denosumab. There will be a rebound phenomena.
Okay. And ma'am, I was reading up that with denosumab, there are incidences of cardiac effusions and other cardiac events. So is a cardiac monitoring necessary during use of denosumab or pre-starting denosumab?
I'm not sure of that, but I don't think it's a very common thing that happens. But more you have to monitor, like someone like Dr. I think Kripa was bringing out the hypocalcemia part. It is very important to monitor with denosumab. Hypocalcemia, hypophosphatemia.
Thank you.
Okay. And there's one more question I wanted to ask you. That is, ma'am, like you mentioned, MRD in myeloma, it should be, we should all begin practicing it nowadays. So, do you routinely send an immunophenotyping for myeloma at baseline?
Yeah, if you are contemplating to monitor the MRD, I mean, that's a whole field by itself, MRD in myeloma, and it has evolved to have a place in myeloma. So if you're contemplating monitoring MRD in myeloma, especially if a patient is going to go for an autologous transplant and you want to know the MRD status prior to the transplant and more important post-transplant, then you need to have a baseline immunophenotyping data on the patient in order to develop your MRD panel. It should be done.
Thank you.
Yeah.
Thank you.
Thank you. Dr. Tejaswini.
And thank you, sir, for the invite. Thank you, ma'am, for the very elaborate talk and very I like the way it was discussed slowly and with each slide given equal time, especially the discussion about the features in MRI, which was very confusing when mostly when we are studying multiple myeloma, we are bored in the middle, like halfway through we are wondering like should I complete studying this. So I like the discussion. Ma'am, I'm not sure if this question is relevant. Poems syndrome, does it have any specific imaging findings in compared to multiple myeloma?
Yeah, so you would expect sclerotic findings, sclerotic lesions. That's what I think you're trying to ask.
Okay. Ma'am, regarding the treatment, we have a case in our ward. Can I ask about it?
Yeah, sure.
This patient, she is having lytic lesions in the maxilla, which is extending right up to the Meckel's cave where the trigeminal nerve comes from. So how do we treat this patient for the bone disease, like radiotherapy? Or we can't probably give zolendronate because it is in the maxilla. That's what I thought.
No, you said the patient has multiple maxillary lytic lesions?
Single large lytic maxillary lesion.
So you can subject the patient to radiotherapy. It's an osseous plasmacytoma. That's what you're trying to say? It's an osseous lesion, bone lesion.
Yes, ma'am. Somewhere
you can give radiotherapy to the patient. If it's a myeloma, if the FNSC has shown that it's a plasmacytoma, you can give radiotherapy.
No, ma'am, it is not a plasmacytoma. It is a patient with multiple myeloma post-transplant who has relapsed with a larger lytic lesion.
So obviously it will have plasma cells in it and you can give radiotherapy. Certainly.
And for the neuritic pain?
So for the neuritic pain, again, the radiotherapy will help if it is leading, if that lesion is leading to a trigeminal nerve compression or trapping it in the pathway. 1, 2, you have other neuralgic pain drugs like gabapentin, which can be given. And thirdly is that sometimes you can give a short course of steroids and also see, a 5-day course or a 4-day course of steroids and see if the pain is very severe. And definitely radiotherapy will help. Even a single dose of radiotherapy will help.
Ma'am, sadly, she's not responding for the gabapentin or the steroids. So you think that radiotherapy will be better?
Yeah, it will help the patient.
Okay.
And obviously, you must be treating the relapsed myeloma also.
Yes, ma'am.
Yeah, you have to treat that also.
Yes, ma'am.
Okay, right. So we move to Dr. Gunjan Prasad. So Dr. Gunjan Prasad, first of all, congratulations for winning the quiz.
Thank you, sir.
Go ahead.
Thank you very much. Yeah. Thank you, ma'am, for a very informative talk. Actually, my question is regarding the PET-CT assessment. I wanted to ask if there is a particular cutoff for SUV max, which can distinguish between the osteoporotic lesions or the myeloma bone disease conclusively.
So, first of all, congratulations, Dr. Gunjan, for your award.
Thank you.
And there are PET criteria. I'm not a radiologist, so I will not be able to accurately answer this. But I didn't cover it. But PET is also moving a long way in myeloma diagnosis. And there are PET SUVs about which I do not know the exact ranges, so I will not be able to tell you. But there are PET SUV ranges about which the lesions are supposed to be highly metabolically active and significant. But even what is more important is that PET is moving on to something like the dual score now. In Hodgkin's, if you know that there is a dual score where the where the PET is compared with the mediastinal pool and with the hepatic pool. The same thing is being adopted in myeloma in terms of the grading of PET. Actually, that data has been given to many centers in the world, and currently they are collating the data, and there is some early publication on it, which will be the scoring, something like the dual scoring for PET interpretation in multiple bone deficiencies. There is published literature. If you go into searching literature on PET for myeloma, you'll find that. There is now it started getting published also.
Thank you, ma'am. And I have one more question, ma'am. After giving the induction therapy for myeloma, after that the response assessment, which modality should be preferred in bone disease?
Yeah, so good. So after you've given the induction therapy and you want to assess the response, it's the conventional response criteria, the International Myeloma Working Group response criteria. I think what you're leading me is to comment on the imaging response criteria.
Yes.
That's an area which I tried to cover is evolving, and especially the functional whole body imaging is an evolving area, and it will be complementary to your conventional response criteria in terms of the M-band and the bone marrow plasmacytosis, the clonality, etc. And it will be complementary to it, especially the MRD part is going to be complementary to it for two reasons, which again I will highlight is one, because of the spatial heterogeneity, which is an inbuilt part of the biology of multiple myeloma, that you are only biopsying the iliac crest to assess the MRD. Whereas you may have clones in lesions, focal lesions sitting elsewhere in the body, which you will miss if you don't do a imaging, whole body imaging. One, that is the most important thing. That is why a functional imaging is important. As of today, if you want to complement your conventional response criteria with imaging data, then it's the PET-CT. Because the functional MRI, which I was trying to tell you, the diffusion weighted MRI, which may actually turn out to be a more sensitive technique than PET-CT, will take some more standardized. Probably in the years to come, it may evolve or receive a assessing response, or maybe both put together will be the most powerful way of assessing response on imaging. But as of today, if you want to complement your conventional criteria of MRD, then you can do it with a PET-CT.
Thank you.
Thank you, Dr. Gunjan. We'll take a question from audience. Dr. Arihant Jain wants to know if there is a patient of suspected myeloma, Crab-Slim criteria are not fulfilled. You've done a PET-CT scan and that's negative. Will you do an additional whole body standard MRI?
Okay. So if the PET-CT is negative, I would stop there and follow up the patient on a yearly basis. I would not go in and do a whole body MRI because all the slim criteria are.
The second question he has, does the extent of bone disease or the pathological fractures after giving steroids for a month decide the duration or dose of dexamethasone?
I didn't quite get the question.
So you have given dexamethasone to somebody for 1 month?
For 1 month.
For 1 month, who has got bone disease and or pathological fractures. Now, does the extent of bone disease or the pathological fracture modify your duration of therapy with dexamethasone or the dose of dexamethasone?
So first thing, I'm not able to understand why dexamethasone has been given for 1 month in this patient. That is something which is not very clear. But just answering the second part of the question, that does the extent of bone involvement or the number of fractures determine the dose of dexamethasone? Dexamethasone is not the standard treatment of bone disease in myeloma. If at all you give high dose dexamethasone or pulse for 4 days is when the patient has very severe pain, or even more important than that is an impending or a spinal cord compression. At that point of time, you give a high dose of dexamethasone in the form of pulse dexamethasone for 4 days. But it is not the standard treatment for myeloma bone disease.
Thank you. Here's another question. What is the role of monitoring bone turnover markers in titrating bone remodeling agents?
Yeah, so this is a research area just now, and a lot of, this is again an area of intense research where biomarkers are being used to monitor the response of the myeloma bone disease. But as of now, it's not a standard recommendation because there are no standard markers, one, and two, there are no standard protocols for monitoring these markers.
Thank you. Dr. Shyam Rathi he has two questions. The first question is, what is your bisphosphonate protocol for a patient of myeloma who has no lytic areas in the bones?
Yeah. So as I said, if this is a patient with active myeloma, irrespective of lytic lesions in the bone which are picked up, irrespective of them, it is recommended to give bisphosphonates, and I choose to give zoledronic acid, but that's a personal choice. And I will give it for a period of 12 to 24 months, depending on the response of the disease to the combination of the agents which have been given for multiple myeloma. So the take-home message is all patients of active myeloma need to be given bisphosphonates, irrespective of being able to detect the bone lesions.
Thank you. And the last question is again from Dr. Shyam Rathi. A patient of myeloma who has achieved MRD negativity in 6 months, what will be your protocol of bisphosphonate?
Okay, so I would give it for a minimum of 12 months.
Thank you. So that was the last question. Is the faculty here satisfied, or you have more questions for Dr. Soniya?
Can I ask one question, sir? Only single question.
Yeah.
Ma'am, actually regarding radiotherapy, so usually there is a school of thought that better to avoid radiotherapy in transplant eligible patients for the stem cell collection and everything. If you have any weight-bearing area, a soft tissue, or any vertebral lesion, is it wise to wait for the response to therapy, or is it okay to give single fraction radiotherapy?
You can very well go ahead and give a single fraction radiotherapy. That will not affect your stem cell collection. Multiple fractions, over 2 weeks or 4 weeks, as I highlighted 30 gray, may have a bearing on the stem cell collection, especially in patients who are above 50, 55 years of age. But single fraction will not have a bearing. You can go ahead. You have to weigh the benefits versus the evil effects.
Yes. Thank you, ma'am.
Sorry, a few more questions have come up from the audience. We'll take them up. Dr. Sanjeev wants to know, denosumab should be used if the GFR is less than 30 or no?
So again, one should avoid denosumab. This is a question which has been coming up again and again. It should be avoided even if it should be avoided with a serum, with a creatinine clearance of less than 30. It should be avoided. But if you have no other, again, it's weighing the benefits versus the ill effects. If you feel that there is a severe bone disease and there is a compulsion to use denosumab, then very cautiously. But generally, I would avoid it with a serum creatinine clearance of less than 30. And much more data is also needed in this area, so it's best to avoid it.
Dr. Vinayak Chikodi has put a question. How do you differentiate between malignant plasma cells and reactive plasma cells, especially when there is an extreme degree of reactive plasmacytosis?
Yeah, so the way to do is to look at the clonality. Any malignancy will be a monoclonal population, whereas any reactive, whether lymphocytosis or plasmacytosis, will always be a polyclonal population. It's to do the clonality studies.
Thank you. Any questions from you all?
Ma'am, can I ask one more question?
Yeah, please.
We had this doubt why this slim crab criteria does not include PET lesions in as a part of the criteria, and will that be included in the future? And my doubt for that was, suppose a patient is having dual malignancy, so both the malignancies can light up because of metastasis. So that may be the reason why it's not included.
No, I think the reason why it was not included is because the slim criteria was laid down in I think 2016, if I'm not wrong, 14 or 16. At that time, I think PET CT had really not evolved as a modality of imaging for myeloma. And MRI, as even till today, is the most sensitive modality for patients.
We have lost Dr. Soniya Nityanand's connection. So in any case, we have almost come to the end. So may I request Mr. Shailendra Kumar to give the official vote of thanks.
Thank you so much, sir, for once again inviting me to close this session and paying my vote of thanks. Extremely delighted every time being associated and being invited on your forum, sir. It's always been very strong learning for us also. And I'm very much thankful to Dr. Colonel Professor Prakash Chitalkar for being chief of the program, and Dr. Soniya Nityanand for a wonderful orator today. It's been a very informative program and extremely delighted to have some of the very, very strong panelists. I want to thank Dr. Akanksha, Dr. Aditi, Dr. Abha, Dr. Kripa Bajaj, and Dr. Ankita Sen, Dr. Tejanswini, and Dr. Gunjan. Thank you so much to all the eminent dignitaries being here on this forum. And once again, I want to thank Mumbai Hematology Group for such an informative session and inviting Panacea as a host for the program. Thank you so much, sir. And I wish you all a very happy and safe time. Thank you so much, sir, and have a wonderful day.
Thank you. Thanks to everyone. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Bye-bye.